the congenital database.
Yes, absolutely. Thank you. Good morning, and thank you very much. This talk is not my talk. It's given on the behalf of the group of people and friends who since several years ago started developing the tools for quality control in congenital heart surgeries on the both sides of the Atlantic. And they represent STS, EACTS, and Aristotle Committee and ECHSA as the organizations that worked together for several years to be able to evaluate the outcomes in congenital heart surgery. Yesterday, when we spoke about the future of the adult database, I said that the most important thing is to, in my opinion and my experience after the several years, is to stop for a while and be sure that we have established the same language on both sides of the Atlantic. So we should be maximally inclusive, and the nomenclature and list of procedures, diagnosis and complications and adverse events should be the same, because otherwise we will not be able to communicate. And that was the vision of Gus Mavroudis, who established in mid-90s the committee. And he invited actually us Europeans to work together. And Yarda Stark and François Lacour-Gaillet and myself and our American colleagues, we were able to start this continuous process of establishing nomenclature and updating continuously nomenclature that of course caused updates of the databases. But if we update the database, we update them both, STS and EACTS, because at the end what we need a huge case mix to be able to analyze the outcomes. We of course need the verification, and there's not time today to talk about it. We need a multi-societal approach to this data set, because those are not only surgeons, but there are also cardiologists and interventionists involved in the process of the treatment of these patients, and of course the reliable method to compare the outcomes. Data sets. Let's start with the data sets. There is a continuous growth of the accumulation of congenital data on both sides of the Atlantic. So we are talking now at the EACTS of a very stable growth of several thousands of patients' procedures data per year, 106,000 procedures divided by age groups, 164,000 procedures from the STS. Twin databases, the same nomenclature, the same language, can be combined any time. And they were combined, 86 centers at the STS. And they were combined, but I'll go to this a bit later. Now, at the beginning of the new century, there were two initiatives that were directed to be able to adjust the risk for congenital heart procedures. The one is a risk adjustment, is a RACS. The other one, Aristotle Complexity Score. What is very important, at that time, our case mix was very minimal. If you realize that the major problem in our analyzing congenital data is that there is a big proportion of the procedures and the diagnosis which are extremely rare, so they are always excluded from the statistical work just for the rareness, because of the rareness, then the volume of the case mix is extremely important. Bigger the volume is, more procedures can be included into statistical analysis. Now, both of those methodologies, RACS and Aristotle, were completely subjective. So they were developed due to the Aristotle thesis. I will now concentrate on Aristotle basic score and Aristotle score. But both of them were based on the thesis that if you don't have the scientific answer, what is scientific answer? Scientific answer would be 100% of procedures completely verified and 100% of data on this procedure, which is completely unrealistic and impossible. So what we are talking about the predictive statistics. Okay? So the value of the opinion of expert has a value of truth. Those are 50 experts from many countries who were involved in developing the score, and the score was the combination of 3 variables. Mortality, expected morbidity. This is something you can measure. This is quantifiable. And the technical difficulty, which is completely subjective. Why technical difficulty is still important? Nowadays, if you look at the outcomes of very complex procedures, like at the bottom of the slide, you will see the mortality for arterial switch, intact septum, VSD, all switches. At STS is 2.8%, EACTS 2.3%, Poland 1.3%. Does it mean that there are very easy, complex procedures that everybody can do? No. They are done by the most experienced surgeons. And that's why we thought that complexity, although it's a completely subjective variable, still has plays some meaningful role. That was discussed, that was questioned many times. This is what the score looks like. This is the basic score for 145 congenital heart surgical procedures. And this is the first experience when we validated the score. And this validation with the first 45,000 cases, it showed that there is quite high correlation between the score levels. The score was divided, as you saw, into 4 levels, between the levels and the real life mortality. So that was the first attempt to validate the score and to try to improve it by changing the completely subjective values into the practical knowledge from the big data set of a biggest case mix. In Europe, we have developed these bubbles, and actually I thought about this figure when you talk about the volume and outcomes. The right lower corner are people, the surgeons, who have the best results. So they operate on the most complex patients with the highest complexity score, and still their mortality is the lowest, is below the mean mortality. As you can see, there is no correlation between volume and outcomes. Actually, the biggest groups, the biggest volumes per surgeons are not in this quarter. We have realized that basic score is the procedure-adjusted complexity, and specifically not only in the congenital, the same in adult cardiac surgery, we needed to include the patient-adjusted complexity, and this is how the comprehensive complexity score was developed. We have added procedure-dependent factors and procedure-independent factors. There's no time to describe it, but they are general factors, clinical factors, surgical technique factors, extracardiac factors. So all branch of the risk factors for the final outcome. That's the final outcome of this exercise. So the basic score up to 15 points, and the comprehensive score adding another 10 points. This is the graph showing you the validation of the comprehensive and basic score with the real data coming from STS and EACTS congenital databases. There is a high correlation between the comprehensive score per given procedure with the real mortality from these 2 databases. But then, as you know, I'm not a statistician, and people who actually are responsible for this work are not statisticians. But we are very lucky having a great cooperation with the Duke. And Sean O'Brien, the Duke, he did fantastic analysis. He used the statistics, the Bayesian methodology, which is the predictive statistics, especially used for the rare situations where you don't have big volumes to analyze it. So the aim of this work was to see what is the correlation between predictive mortality developed through the statistics based on the huge volume with the observed mortality in the huge case mix. So that's how the EACTS-STS mortality score was developed, with a range from 0.1 to 5 for 100 procedure. Look, that was only statistically possible for 100 procedures. We had to exclude the rest of the procedures due to their rareness. The score appeared to be very significant predictor in the logistic regression model, and also the levels, not the continuous score, but also the levels, the 5 levels, they appeared to be very strong predictors of death with a quite good specificity and discrimination between the levels. This is something I really love. You know, we have taken 4 models used during 10 years. And of course, this EACTS-STS score appeared to be the strongest predictor of mortality. These model, score and categories will be, until the end of this year, inbuilt in both STS and EACTS databases. And all risk adjustment for mortality will be done using the scores because they are statistically most powerful. But what I really like to see is that if we go back to Aristotle and Doxa, the guy said 350 years before Christ, if you don't have the data, the opinion of experts has a value of truth. After this very extensive statistical analysis, we know now that the basic Aristotle score, which is completely subjective, had nothing to do with it is just 50 people and their experience, nothing else, no measurements, appeared to be quite a strong predictor of death. Morbidity. It will be short. Morbidity is not a big success. We didn't know how to touch the problem because we initially thought that ICU length of stay can be one of the predictors and can be one of the factors of the morbidity. ICU length of stay sometimes in some countries means that patient is discharged home from the ICU because of the better payment in ICU. It does not reflect morbidity at all. It is just local logistics and local financial situation. Cumulative ventilation time, it's a problem, I have to admit, in both databases, STS and EACTS, ventilation time is available in 50% of patients only. So we failed. We thought that probably cumulative ventilation time, postoperative length of stay, and major complications listed here could be used for creating this morbidity score. So 56,000 patients, we have excluded the procedures which were least frequent, and we developed the score that covers, unfortunately, only 95% of patients and 81% of procedures, which is not enough. Anyway, we have used the score to see which procedures carry the most important morbidity. Those are the procedures. You know, at the end, it looks that it's quite good correlation between length of stay, ventilation time, which are the basis, which gives the base for the score, and the morbidity index. And even morbidity levels look quite good. And this looks like a linear relation between this morbidity index and for the given procedures. But still, we need to do it again and again. So what we did in the summary, we have updated the database, we have updated nomenclature, we have enclosed, we have added more preoperative risk factors for early morbidity, and we will start this exercise again. Comments? As I said, 10 years ago, Aristotle complexity score was entirely subjective, was just temporary instrument which was needed to do all this statistical work. And of course, it will be continued because, as you can see, the mortality index covers 96% of patients. Why not 100% of patients? Because there are still procedures which are too rare to be included from the statistical point of view. The morbidity is a very important measure. What's going on in congenital heart surgery? Whatever patients, the average mortality went down to 4%. If patients cannot go off bypass, patients is on ECMO, is on VAD, the survival improved, the morbidity is increasing. And morbidity is a surrogate for cost, for overall suffer of the patients and families, and the final outcome, early or late. So this is something we need to do with STS together. Now, what is available, together with the Japanese database, which is, we are not twins, we are triples now. We have 3 databases that are the same nomenclature, the same data sets. Adding this all together, it's over 300,000 patients, okay? That all the changes that we implement, including perioperative, preoperative risk factors, they are done at the same time in 3 databases. We will work on the morbidity index, but I have to say at the end one thing. This is not the product. This is not something you can sell. This is the process that took several years, needs to be continued, needs to be re-evaluated all the time, and it's nobody's personal achievement. It's a great example of the work of the group of people very much involved, doesn't matter which continent, and at the end it's a patient that should benefit from it. Thank you very much.